Hey Farm Buddies, it's Lisa. This week we're talking about the respiratory system. So we're covering chapters 31 through 33. Don't be too scared when you see how many slides are in this PowerPoint deck. I have all three chapters into one. Remember, I like a lot of pictures, so sometimes I'll make whole slides devoted to pictures. And I also have those embedded questions and answer slides in there. So it's really not a lot. There's a lot of slides, but that's just my style. So in this module, we're going to talk about, like I said, the respiratory system. Chapter 31 is pretty simple. It's all drugs that you are familiar with. If you've ever had a cough or a cold, you should recognize a lot of those drugs. Chapter 32, we're talking about allergies. So again, a lot of drugs you've probably heard of, antihistamines and such. If you have allergies, probably do because we live in Ohio. So you've probably heard of these drugs too. So they're pretty easy. Chapter 33 is the hardest of the three, but it's still really not too bad. It's drugs for asthma and bronchoconstriction. So we'll talk about that a little bit. It's not too bad. Let's get ready. We're starting with Chapter 31, Drug Therapy for Nasal Congestion and Cough. All right, so let's talk about some of the conditions that we're going to be treating with these medications. First thing I want to go over really quickly is your upper respiratory tract. So the common cold usually affects your upper respiratory tract. So what am I talking about when I'm talking about my upper respiratory tract? That's my mouth, my nose, my pharynx, my larynx, and my trachea. So basically, from like your clavicles up, your throat upwards, that's your upper respiratory tract. Lower respiratory tract is going to be basically clavicles down. That's going to be your bronchi, your bronchioles, and the alveoli. Basically, trachea down to the lungs. Common respiratory disorders are going to happen when bacteria or virus pass through our basic defense mechanisms and start to invade this respiratory tract. So what are our defense mechanisms? So we've got nasal hairs, we've got mucus, we've got cilia, we've got cough and sneeze reflexes. All of those things are there to try to prevent the viruses and bacteria from getting in. We all know from all the COVID stuff how quickly viruses can spread, so you can see why it's so easy, to spread these upper respiratory infections around. Specifically, we're going to talk about the common cold here. So your common cold, this is what we get 2 to 4 times a year, is usually normal for adults. Going to be a viral infection. So again, viruses, we're going to pick it up on a surface, on skin, not washing our hands, not using Purell or Lysol. And then we are going to touch our face, our nose, our mouth, our eyes. And then that's going to basically put that bacteria or virus right into our bodies, and then it can start to take over. Again, common cold is going to be a virus, so antibiotic isn't really going to help you. You just kind of have to let it run its course. The next common upper respiratory disorder we're going to talk about is sinusitis. So sinusitis happens when the lining of the sinus cavities become inflamed or infected. So because of this inflammation or infection, that swelling is going to block off the fluid that usually drains out of there, and that blockage can block in microbes and it can lead to infection. So the main cause of sinus infection is actually that blockage of fluids because of the swelling in there. So then rhinitis, which is your runny nose, rhinitis is going to be the most common cause of sinusitis because your nose is running, you're blowing it constantly, it starts to get inflamed and irritated, and then that swelling kind of pinches off those sinuses, and then that fluid gets trapped up in there. Anything that kind of sits stagnant gets gross, vector for infection, and boom, you've got a sinus infection or sinusitis. All right, question number 1. Is the following statement true or false? The common cold is caused by many types of bacteria. And correct answer is false. That one was super easy. Hopefully you guys all got that. I got to warm you up before we get into this long lecture, right? So correct answer is false. Common cold is going to be caused by a virus. So I'm sure we all know the signs and symptoms of colds and sinusitis, but here we are, we've got to talk about them. So first one we're going to see is nasal congestion. So stuffy nose, right? Hard to breathe. Nasal congestion happens when the nasal passages become blocked and swollen from those inflamed blood vessels. Next signs and symptoms you might get is a cough. So your cough is really a protective reflex. It's in response to irritation or inflammation. There's actually a cough center in your brain, in the medulla. Sometimes it can get triggered by some irritation, and that's why you just cough and cough and cough. So the big thing to think about when you're thinking about coughs is whether it's a productive cough or a non-productive cough. So just like it sounds, are you producing anything or are you not producing anything? So if we've got dry air, dry mucous membranes, some kind of tickle in your throat, you're usually going to see a non-productive cough. Nothing's coming up, right? You're just coughing. Nothing's coming up. Productive cough is usually what happens when you've got a cold, you've got postnasal drip or some kind of throat irritation causing more secretions. So that's when you're going to have that productive cough. So you're coughing up some gross mucus. Next thing we're going to talk about, increased secretions. So again, this is all kind of symptoms of that common cold or sinusitis. So those increased secretions are going to start running kind of down your throat into the bronchi. You can get them from all types of things, anything colds, pneumonia, any kind of upper respiratory infection like that's going to trickle down, and it can get clogged up in your bronchi. So those extra secretions you can also get from irritations like allergies or smoking, and sometimes you'll get them after things like surgery. So in surgery, they put that tube down your throat, right, to help you breathe. It can be irritating to that lining of your throat. That irritation can cause a lot of secretions, so you get a lot of stuff running downhill, running into the lungs. One of the big things we teach you guys about taking care of surgical patients, right? Coughing and deep breathing. We mention it all the time. So the kind of coughing we're asking for is going to be a non-productive cough. I basically just want you to, it just helps kind of mobilize things, help you take some big, deep breaths. So those excess secretions, they can really impair your respirations if we don't help clear them out. That's why that coughing and deep breathing is really important. Even though you're not coughing anything out, it is helping to kind of mobilize some of those secretions after surgeries. So nobody likes this nasal congestion. What are we doing to get rid of it? Luckily, we have these beautiful meds. So to treat our nasal congestion, we're going to take a nasal decongestant. We've got two different kinds, pseudoephedrine or oxymetazoline. What these meds are going to do is relieve that nasal obstruction and discharge by producing vasoconstriction. So remember, we said the stuffiness comes from a lot of swelling in there. Those blood vessels get swollen and it starts blocking off the flow. So we give these medications and they're going to cause vasoconstriction. It's going to decrease the size of those nasal blood vessels, help you breathe a little bit easier. So how they work is they stimulate the sympathetic nervous system, right? That's your fight or flight. So part of that fight or flight is going to be vasoconstriction. So these drugs are going to be contraindicated in things that are dangerous to have that vasoconstriction. So if somebody has severe hypertension, coronary artery disease, glaucoma, that vasoconstriction can be really dangerous. We can also see some contraindications with antidepressants because it's going to make the effects of the antidepressants a little bit stronger if you mix those two together. So again, because of that sympathetic stimulation, we need to use a lot of caution if we're giving pseudoephedrine to anyone that has cardiac arrhythmias, hypertension, coronary artery disease, or glaucoma. So pseudoephedrine, that's going to be the one that causes a lot of vasoconstriction. That's oral. Sudafed, most of your cold medications are going to have that pseudoephedrine. The oxymetazoline, that one's going to be the nasal spray. So like Afrin. So this one's kind of nice because it's an intranasal spray, so it has less systemic effects. It can be tolerated a little bit better by people that have hypertension and coronary artery disease. But the big concern with the oxymetazoline is you only want to use it for 3 to 5 days. So for giving these nasal decongestants, if you're taking an oral medication, you can give that nasal decongestant with or without food, doesn't really make a difference. If you are giving that oral nasal decongestion, so you're going to have a systemic effect, we really want to monitor our cardiac side effects. So watch for hypertension, watch for any palpitations. You also want to be careful not to crush any extended release tabs. Sometimes you're going to see this extended release medicine, so that they say, you only have to take it every 8 hours or every 12 hours. And then some of it's kind of a quicker release, so those would be okay to crush, but watch out crushing those extended releases. So now we've got our patient teaching. So we want to encourage a lot of fluids. Fluids are going to help thin those secretions, so make it easier to cough, make it easier to blow your nose, help clear all that stuff off. Humidification, so that means we want to make the air really humid. That moisture is good for our respiratory tract, makes things not as dry and irritated and more likely to be inflamed. So humidifying the air, making the air really moist, is helpful when you're sick. Make sure you're not taking these medications any longer than the package recommendations. Usually package recommendations are going to be about 3 to 5 days, especially when we're talking about that nasal decongestant. The intranasal, the oxymetazoline, the Afrin. So that one, 3 to 5 days, or else it's going to cause what's called rebound congestion. And this is kind of cool because your body is always trying to correct itself. So if you take this nasal vasoconstrictor, your body's saying, hey, I don't want to do this, and it's going to kind of overpower it. And it's actually going to make you more congested than before you were taking that medicine. So you want to use this Afrin or the oxymetazoline a couple days, and then you have to cut it out just through the worst part of your cold. Another couple things have to do with that fight or flight stimulation. So you want to avoid caffeine. It's going to, cause increased vasoconstriction, which can be dangerous. You have to also be really careful about accidental overdose. There are a ton of combination cold medications. If you guys have ever walked down the drug aisle in Target, there's a boatload, right? So a lot of things have more than one ingredient. So be careful you're not overdosing on accident. You want to avoid using this medication again in hypertension because of that extreme vasoconstriction. There is a different type of medication that is made specifically for people that have hypertension and cardiac disease that doesn't have the vasoconstricting effects. And last thing, you want to make sure if your patient is taking the nasal spray, make sure you know the proper way to use the nasal spray. Told you this wasn't a bad lecture, right? We're already up to question number 2. Question number 2, is the following statement true or false? Sympathomimetic drugs are used to relieve nasal obstruction and discharge. All right, correct answer was true. If you guys got tripped up on this one, it's probably because you didn't know what sympathomimetic meant. So sympathomimetic means that you are mimicking my sympathetic nervous system, right? Sympathomimetic. So if I'm mimicking my sympathetic nervous system's fight or flight, so it's going to cause some vasoconstriction. So causing that vasoconstriction, right, it's going to relieve that nasal congestion and swelling. So it's going to decrease the blood flow to the nasal mucosa, kind of dry it up in there, and it's going to lead to relieving that nasal obstruction and slowing down that discharge. The next class we're going to talk about is antitussives. So these are your cough medications. Our example antitussive is going to be dextromethorphan. Dextromethorphan is going to suppress a dry, hacking, non-productive cough. So remember, non-productive means that you're not coughing anything up. It's just kind of an irritating, dry cough. We have a couple different options when we're talking about this type of antitussive. So you can take a centrally acting antitussive. This is going to be a narcotic medication. One of the side effects of codeine is actually that it's an antitussive. So when I was young, we used to be able to take cough syrup that had codeine in it, and you were not coughing, you were in good shape. But they don't let that happen anymore because of the whole opioid crisis. So there's narcotic antitussives, and then there's also these non-narcotic antitussives. These are the ones that you guys are more familiar with, the non-narcotic antitussives. So centrally acting means that it's going to act on your whole body. So something that we would take orally. So that would be like your traditional cough medication. Like the dextromethorphan. Sometimes you guys will see, like in the picture down here, you can buy the cough syrup with the DM, and the DM stands for that dextromethorphan. Nice job butchering that, Lisa. Dextromethorphan. You can also buy benzonate, which are these little yellow capsules in the picture down here. It's actually an oral, like a pill form of cough medication. Works pretty good, and it doesn't have that really gross taste. Then we also have those locally acting antitussives. So those are just going to be like cough drops or lozenges that you can suck on that are going to, kind of smooth the throat, and it'll kind of get rid of that tickle. So important thing to remember here with the antitussives, we're going to take an antitussive for a dry, non-productive cough. So as a nurse, if we are giving these antitussives for our dry, non-productive cough, generally if we're given a cough syrup, you want to not take anything to eat or drink for about 30 minutes after you're taking that liquid. Same thing with a cough drop. You don't want to eat or drink other stuff while you have that cough drop or lozenge in there, because the whole point is you want it to kind of go down the throat to soothe that irritation. There are some drug-to-drug interactions with a lot of antidepressants, so be careful if you're mixing these antitussives with antidepressants. We also want to make sure that we are doing some good patient teaching if we are giving our patients this kind of medication. So again, make sure we're encouraging adequate fluid intake, and humidification helps moisten up that whole respiratory tract. You don't want to take these medications longer than a week without seeing your doctor. If you're still coughing after a week, you might want to get worked up for something a little bit more. Again, be careful of that accidental overdose because of all of those combination cold medications. Our next medication is an expectorant. So our example expectorant is going to be guaifenesin. Everybody knows it as Mucinex. So guaifenesin is going to liquefy respiratory secretions, and it allows for easier removal. This one's going to be good for a productive cough. So the Davis Drug Guide uses the word tenacious sputum. I think that's one of my favorite adjectives to describe sputum, tenacious. So this is going to help thin out some really thick and tenacious sputum, make it easier for you to cough up. This is going to be used for a productive cough. Just helps loosen everything up so you can get it out of your lungs. This kind of medicine, an expectorant, is not going to do anything if you just have that dry, non-hacking cough. This is when we need to get something out of there. So guaifenesin has no major side effects. In the only contraindication is allergies, so you don't really have to worry about that. So we're going to skip to nursing considerations. So as a nurse, what do you need to know if we are giving expectorants like guaifenesin? Guaifenesin is an extended release tab, so make sure you're not crushing those extended release tabs. You want to have the patient swallow that tablet whole. As far as patient teaching, make sure you're teaching, again, your patient to have adequate fluid intake and hydration, good for the respiratory tract. Teach your patient not to take longer than a week without seeing their doctor. On occasion, some patients with some chronic respiratory problems like COPD will take guaifenesin long term, but make sure that nobody that's not been told by their doctor to take it long term is taking it longer than a week. You need to see the doc if you need to take it longer than a week because there's something going on. Again, avoid accidental overdose. And we want to make sure that we are teaching our patient coughing and deep breathing so it can help get that stuff out of there. So if you're in the hospital setting, you can give your patient an incentive spirometer. Remember, they're going to suck on that real hard and it's going to help expand their lungs. We can also give them the little green guy there. It's called an acapella. Sometimes you'll hear it called a pickle. It has a little vibrator valve in there that helps to kind of vibrate the walls of the lung and help cough up some of that stuff. So you have your patient, drinking a lot to thin those secretions, practicing coughing and deep breathing, taking their guaifenesin is going to help break up that productive cough. So very similar to the expectorant, we have a mucolytic. So mucolytic is like the highest power expectorant. So mucolytics we're going to use with chronic respiratory issues. This is like way more serious lung disease than what we would use an expectorant with. So our mucolytic, our example drug is acetylcysteine. You may remember or you will learn about acetylcysteine being used for a couple different things. We actually can use it in the event of an acetaminophen overdose, so a Tylenol overdose. Acetylcysteine is going to be your antidote, but in this case, we're talking about it as a mucolytic. Acetylcysteine, you will find out if you ever take a big whiff of it, it smells like disgusting rotting eggs. Super gross. So I hope that you never need to give acetylcysteine because it's horrid. Acetylcysteine is going to help liquefy the mucus in the respiratory tract. It's going to be an inhalation. So they're going to breathe in and out, and that'll help liquefy that mucus in the respiratory tract. Again, this is used in chronic lung disease. So really severe lung disease like cystic fibrosis, very severe asthma. This helps break that up a little bit. So like I mentioned before, acetylcysteine can be given different routes depending on what we're using it for. In the respiratory case, we are talking about inhalation. So because we are giving it as an inhalation, we want to make sure that we're monitoring our airways. Because it will liquefy the secretion so well, you want to make sure your patient is able to cough and clear their airways to clean, be able to spit up all that mucus that they're going to be coughing up. Usually they tell you to have suction equipment available because if they're that sick with these severe respiratory illnesses, sometimes they're not able to cough everything out on their own. So a suction equipment's good to have available. Also, you want to make sure you remove that residue from the face of the patient after this. Like I said, it smells disgusting like rotting eggs. You don't want to leave that on anybody's face. That would be awful. As far as patient teaching, again, we want to encourage adequate fluid intake and encourage coughing and deep breathing to get all that junk out of the lungs. So I just want to take one quick second and talk about over-the-counter cold medicine. So like I mentioned a couple times in the lecture, you have to be careful about accidentally overdosing on these combination medications. A lot of the over-the-counter stuff is going to include antihistamines, nasal decongestants, even has pain medication in there. Some of them have antitussives and expectorants, so you have to be really careful when you're reading through to make sure that you're not accidentally taking something that has two ingredients. For example, Claritin D. You get the antihistamine from the Claritin, but then the D is a decongestant. So then you're also getting some pseudoephedrine in there. And if you took something with pseudoephedrine in it on top of that, you could really, give yourself really high blood pressure, even risk for a heart attack. So be really careful when you're advising people about what medicine to take. Even though it's over the counter, it still can be dangerous. Next thing I want to talk about is the popularity of pseudoephedrine. So pseudoephedrine, like we said, vasoconstrictor, also can be used as an ingredient in methamphetamine. Fun trivia, right? So because meth got so popular, they had to move all the cold medications that contain pseudoephedrine behind the counter, and you usually have to show your ID to get those things now. Well, because people don't like going through all that work, they're switching over from pseudoephedrine to phenylphrin. So phenylphrin is not as potent as a vasoconstrictor, so it still is going to give you some vasoconstriction and relieve your cold symptoms, but it's not going to be as dangerous. So phenylphrin is also going to be the medication that we would recommend to people that have cardiac issues or glaucoma that aren't able to take the pseudoephedrine. Phenylphrin, you'll notice, is in all the cold medicine that you can just buy in the aisle now. It's also labeled as this corticosteroid HBP, which is for high blood pressure. It's just going to have that phenylphrin in there instead of pseudoephedrine. Also, there's all kinds of, I don't know if it's research, I guess you'd call it zinc, echinacea, vitamin C. There is some research that shows it may help if it's taken early in your cold signs and symptoms. They say to take it within the first 24 hours for the best effect from that over-the-counter stuff. Hey, look at that. We're already up to question number 3. A common mucolytic used to liquefy mucus in the respiratory tract is A, acetylcysteine, B, ipratropium, D, dextromethorphan, or D, pseudoephedrine. And our correct answer is A, acetylcysteine. Remember, acetylcysteine, the key term is liquefy. Do you remember what the other medication is that is similar to acetylcysteine? Yes, guaifenesin. So guaifenesin is an expectorant. It thins those tenacious secretions. Acetylcysteine is going to liquefy the secretions. It's an inhalation for chronic respiratory disease. Both of those you want to use for a productive cough, not a dry, non-productive cough. All right, question number 4. Cold remedies listed as non-drowsy or labeled as daytime formulas do not contain A, a decongestant, B, a first-generation antihistamine, C, a pain reliever, or D, any of the above. All right, the correct answer was B, a first-generation antihistamine. If you're like, Lisa, what are you even talking about? We haven't talked about antihistamines. I know this was a good segue into our next chapter, so I left it in there. So keep this in mind when we're moving forward. So first-generation antihistamines, major side effect of those early antihistamines is drowsiness. So when you're thinking about first-generation antihistamines, think about diphenhydramine or Benadryl. You can use that to go to sleep at night. You can also take it to treat your allergies. So if you're reading through the ingredients on, say, Dayquil, Dayquil is not going to include any diphenhydramine, but NyQuil is going to be full of diphenhydramine, so it's going to put you right to sleep. All right, look at this last question for the chapter. I told you guys it wasn't too bad. So question number 5. The nurse caring for a patient with nasal congestion who is using the over-the-counter decongestant oxymetazoline. The nurse counsels the patient that this medication should only be used for the time recommended on the package and no longer, because excessive use may cause A, copious lower respiratory tract secretions, B, ringing in the ears, C, rebound nasal congestion, or D, a suppressed cough reflex. And the correct answer was C, rebound nasal congestion. So remember, using nasal decongestant sprays more than the amount of time recommended on the box can cause kind of a dependence by your body on that medication. So your body's going to want more and more and more to cause that vasoconstriction. So then once you cut it off, your body's like hooked on it, and you're going to get more secretions and more swelling, and it's like you're getting sick all over again. So when you're using these nasal sprays, you want to use them for as short as possible. Usually they only recommend 3 to 5 days for these nasal sprays. So next we're going to start chapter 32, drug therapy to decrease histamine effect and allergic response. I put flowers on here just to make you think of histamine and allergic response, but I also want you to keep in mind that allergic response can be other things. It can be dogs, it can be food, it can be poison ivy, medications, all kinds of things you can have an allergic response to, peanuts, whatever it is. It's all going to be the same trigger and the same kind of cascade of hormone effects. So anytime we're talking about histamine and allergic response, don't automatically think like seasonal allergies. The main allergy drug we're going to talk about are antihistamines. To understand how antihistamines work, let's talk about how histamine works. So histamine is going to be the first chemical that's released in our immune and inflammatory response. It's stored in most of our body's tissues, but it's extra high stores in tissue exposed to the environment. Things like our eyes, our nose, our lungs, and our GI tract. So in these tissues, histamine is going to be found in the mast cells and circulating in basophils. So it's kind of circulating around looking for any kind of allergens or irritants. This histamine will be released in response to an irritating stimulant, like I said, an allergen, an injury, even extreme cold can sometimes set off this allergic response. So then this histamine is going to bind to the receptors, and it's going to set off this whole cascade, causing vasodilation, mucus, itching, all kinds of really gross stuff. I put this really good TED Ed video on there. It's only about 5 minutes, has to talk about seasonal allergies. Kind of interesting. So when that histamine is released and it stimulates the receptors, we're going to have a whole cascade of awful things that happen that cause this allergic response, right? So we get the irritating allergen that comes in, it gets picked up by our body. Histamine is released. Histamine is going to cause constriction of smooth muscles in the respiratory tract. So you can get respiratory distress, you can get wheezing. It's going to cause stimulation of the vagus nerve. That can cause coughing, can also cause bronchoconstriction. You're going to get increased capillary permeability. So fluid can move into the subcutaneous tissue, so you can get edema. You'll get increased mucus production, right? Mucosal edema, congestion, a runny nose. You can have stimulation of your nerve endings that can cause pain and itching. Dilation of capillary beds can cause flushing. We even see GI tract effects. So you can have increased secretion of gastric acid. You can have some sympathetic nervous system stimulation. So increased heart rate, increased force of contraction, so increased work on the heart. So this whole thing can happen just in response to, one little thing. Maybe you got exposed to shrimp or peanuts or chocolate, whatever that irritant is. All of these things are going to happen. So you get respiratory effects, you get heart effects, nerve effects, lots of mucus. I mean, it's really a strong response. Our body's not horsing around. So now that we've talked about the effects of histamine, I kind of want to back it back up and talk about what stimulates your body to release that histamine and cause these allergic reactions. So we're going to talk about hypersensitivity reactions. And hypersensitivity, just kind of like it sounds, you're hypersensitive to an allergen. So it's kind of an exaggerated allergic response. These exaggerated responses can actually get really serious, can lead to tissue damage, serious illness. These are like anaphylactic reactions. And it's all caused by an abnormal immune response. So remember back to A&P when we are thinking about our body's immune system. So if our body's immune system gets stimulated by something and it's already fought it, remember we have those memory B cells and they are going to make an antibody. When that antibody is circulating around, your body can ramp up an immune response real quick because it's seen this antigen. The antigen is just something that your body's marked as harmful. So it could be a virus or a bacteria, but in this case, it can be something totally benign, like shrimp. So say that your body has marked shrimp as an antigen or, the severe irritant. So your body's going to see that shrimp and it's going to say, hey, I have an antibody. I know I don't like this. And it's going to go crazy and make this exaggerated anaphylactic type reaction. So it can get really serious once you have those antibodies that know how to attack the antigen, which is going to be the allergen in this case. So we have 4 different types of allergic reactions we're going to talk about. Type 1, 2, and 3 are antibody molecules. Type 4 is an antigen-specific T cell. I know you're thinking, whoa, Lisa, this is kind of a lot. Don't really worry about the antibody molecules or the antigen-specific T cells. Just kind of understand the basics of what I'm going to tell you and kind of the examples of these immune responses. First type of allergic reaction we're going to talk about is the type 1 hypersensitivity. So type 1 or immediate hypersensitivity. It's called this because it happens within minutes of exposure, nearly immediately. So type 1 hypersensitivity is caused by activation of mast cells by IgE. So when this antigen or the allergen, the antigen meets the IgE, histamine is released and then the reaction happens. So this reaction can happen so fast because, again, your body's made those antibodies that look for that antigen. So when the antigen finds the antibody, boom, allergic reaction. So let's say that you ate shrimp once and maybe you had a little reaction. Like we said previously, right? You get like a little itching in your mouth and then you kind of forget about it. Your body didn't forget. It's made an antibody and that antibody is focused on shrimp. So the next time you eat the shrimp, your body is on it. It picks up that shrimp and it, boom, full on allergic reaction. So within minutes, type 1 hypersensitivity. And this is how anaphylactic reactions can happen, right? So anaphylactic reactions can be mild to severe. Usually they're pretty severe. It can be life-threatening, respiratory distress, cardiac collapse. We're talking like for real allergies, right? So I like this little picture here. You can kind of see simplified type 1 hypersensitivity. It's reminding you IgE because it's immediate with both the I's there, right? Reaction happens within a minute. So you can see those little antibodies that are swimming around the IgEs looking for the ragweed. When they find the ragweed, they're going to run over there to that mast cell and it's going to say, woo, 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 we found the ragweed, we got to go crazy. So that's going to be your type 1 hypersensitivity. Our next type of allergic reaction is going to be much less common. It's going to be a type 2 or cytotoxic hypersensitivity. This response is caused by the antibody IgE or IgM. And these 2 antibodies are going to cause direct damage to the cell's surface. So these cytotoxic reactions include things like blood transfusion reactions, hemolytic disease of newborns, and hemolytic anemia. So all of those, when that reaction happens, it is going to destroy some cells. These type 2 reactions are often seen as a reaction to certain medications like penicillin and heparin. Type 3 hypersensitivities are going to be the next one we're going to talk about. So type 3 hypersensitivity, or an immune complex reaction. This one's going to be started by IgG or IgM. So IgG or IgM, they're going to form an antigen-antibody complex. So antigen is the bad guy, antibody is the good guy. They're going to kind of stick together like you can see in the little picture there. And those clumps start an inflammatory reaction inside the tissue. One example is serum sickness, and this happens when you get an excess of those antigens and the antibodies clumping up, and it can cause permanent damage to your tissues. This reaction is pretty rare. Occasionally you'll see it after an antibody transfusion, or it can happen as a reaction to some medications. Our last hypersensitivity is type 4. Type 4 is also known as delayed hypersensitivity because of the delay in reaction time. So this cell-mediated response happens after exposure to an antigen, and a T cell reacts and it causes inflammation. This is similar to the type 1, but since we don't have that antibody already looking for the antigen, it takes a little bit longer to react. So remember, in type 1, it's immediate. You're going to get that immediate strong reaction because you already have the antibodies. Type 4, it's going to be delayed because we don't have those antibodies already looking out. So you might see this delayed reaction with things like your TB test. Remember, you go back in 3 days and look at it. You might also see it with contact dermatitis or graft rejection. You can also see this with things like poison ivy. You get exposed to poison ivy and you're fine for a couple days, and then all of a sudden you have poison ivy. So it took a couple days for your body to kind of get on board and decide that it didn't like whatever that antigen was. Again, type 4 is going to be a delayed reaction. All right, here we go, guys. Question number 1. Is the following statement true or false? Histamine is the first chemical mediator released during the inflammatory response. Nice, that was an easy one. Correct answer, right, is true. Histamine is going to be that first chemical mediator that's released during the immune and inflammatory response. It is made and stored in most of those body tissues. Remember, especially those ones exposed to the outside, so eyes, nose, mouth, GI tract. What cells specifically do you guys remember that release histamine? Oh, I think I heard you say it. You're right. Mast cells and basophils. So they're running around looking for those antigens. Once they find those antigens, they're going to release histamine, and it's going to start this reaction. All right, question number 2. Is the following statement true or false? 4 classifications of hypersensitivity reactions exist. And our correct answer is true. We do have those 4 classifications of allergic reaction. Remember, type 1 is going to be immediate, like anaphylaxis. Type 2 is going to be damage to cell surfaces from a blood transfusion reaction, something like that. Type 3 is going to be those antigen-antibody complexes, like serum sickness. And then type 4 is going to be our delayed hypersensitivity, like contact dermatitis. And then here I come with the study tip for you. Our 4 hypersensitivities, A, C, I, D. Anaphylaxis, cytotoxic mediated, immune complex mediated, and delayed hypersensitivity. Just because I love you guys. So now we know how these allergic reactions start. Let's talk a little bit more about the signs and symptoms. So what are you going to see when your patient's having an allergic reaction? So pretty basic, we're going to see allergic rhinitis, which is inflammation of nasal mucosa, caused by that type 1 reaction to an inhaled allergen. So you guys know how this is. We all live in Ohio. It's awful. Say you're going for a hike and you're breathing in all of that pollen. All of a sudden, you've got nasal congestion, you've itchy eyes, sneezing, a lot of drainage, itchy eyes, throat, ears, all common. Your seasonal allergies, they call it hay fever sometimes. So that's going to be like, every spring when the seasons are changing, every fall when the grass is growing, you get some kind of seasonal allergy, allergic rhinitis. You can also have what's called perennial allergies. And so these are going to be non-seasonal allergies. So things that can happen all year around. So perennial disease, you might see things like dust mites or molds or animal dander that are going to lead to, again, those allergic rhinitis symptoms. So it just kind of depends on if it's a seasonal thing or if it happens year round, how you're going to define that allergic rhinitis. So we talked about the allergic rhinitis from the inhaled allergens. Next, we're going to talk about allergic food reactions. So usually food allergies are related to a protein like shellfish, seeds, bananas, eggs, milk, soy, peanuts, or tree nuts. All those have a high risk to be triggers for anaphylaxis. Children seem like they are allergic to things like milk, eggs, wheat, and soy. They say breastfeeding helps to prevent allergies as a child, but actually can increase them as the person ages. There's really no way yet to prevent any food allergies. Just as a fun trivia fact, shellfish is the most common food allergy in adults. Next time you're at a party and you need something to talk about, there you go. So we talked about our inhaled allergens. We talked about our food allergens. Let's talk about our skin allergens. Contact dermatitis. How about these pictures, right? Oof. So contact dermatitis, which is going to be a type 4 or delayed reaction allergy. Remember, it's from direct contact with the allergen, like poison ivy, cosmetics, some metals. And these pictures are actually from someone that was allergic to tattoo dye. Looks like they got some kind of lizard tattoo. Maybe it's a good thing they were allergic to it. And then the next one is from like a necklace, like a metal, causing that delayed reaction. You can see the affected skin becomes inflamed, warm, looks like it's swollen and itchy. So usually the rash happens about 24 hours after contact with the allergen. Blisters can form, it can start draining, it can actually become infected, so it can be pretty gross. All right, last but not least, we're talking about allergic reactions from medications. How about these pictures too? That's a double woof. So these medication allergies can happen from any drug, and it can affect any body tissue. The drug reactions are kind of difficult to diagnose, as one drug might cause multiple symptoms. So maybe one medication causes a rash, it can cause a fever, or it can cause some kind of hematologic reaction. So the reaction could be from a preservative or from a dye that's not something that's the actual drug. So sometimes generic medications will use a different coating than the name brand medications. You could have an allergy to that, not necessarily the actual medication. So symptoms are going to vary. Most common symptoms you're going to see of medication reactions are going to be full body skin rashes, itching, fever, those hematological changes like hemolytic anemia, liver toxicity can happen. And these reactions are usually going to take a week to 10 days after initially starting that medication. And they're usually going to stop a few days after you have stopped taking that medication. So if you're taking care of a patient that comes in with all of a sudden this crazy rash, one of the first things you want to think about is, have they started any new medications, or have they changed, from a generic to a name brand that maybe there's some kind of ingredient that's a little bit different. All right, question number 3. I put a lot of true and false in here. I'm going to have to make these harder for you guys. Question number 3. Is the following statement true or false? Allergic rhinitis is caused by a type 3 hypersensitivity. And the correct answer is false. Allergic rhinitis is inflammation of the nasal mucosa caused by a type 1 hypersensitivity. Remember, it's type 1, it happens really quickly. So you go outside, you inhale that pollen, and all of a sudden you start having runny nose, watery eyes, sneezing, itching, all that good stuff. Do you guys remember what a type 3 allergic reaction would be? Serum sickness. Nice job, guys. So what kind of drugs are we taking to relieve these allergy symptoms? So if histamine is going to be the root cause, right? First thing that's released when the allergen's caught. So antihistamines are going to be the best choice for stopping that kind of allergic cascade that happens from the histamine. So antihistamines are going to relieve the symptoms, but they're not going to cure the allergy. So if you look at this little picture here, you can see the antihistamine just kind of plugs on that histamine receptor and says, you're not getting in here. Nothing's happening. So it just stops that histamine from attaching and causing that allergic reaction. So antihistamine, just like it sounds, is going to make that histamine unable to work. So again, it's going to relieve the symptoms, not going to cure the allergy. Once you're allergic to shrimp, you're going to be allergic to shrimp. We can use antihistamines to help with the symptoms of allergic rhinitis, anaphylaxis, allergic conjunctivitis, so that's just those itchy red eyes, medication allergies or pseudo-allergies, which we'll talk about later, blood and blood product transfusion reactions, dermatological conditions, so like skin rashes, poison ivy, things like that. Antihistamines, they are fantastic. So let's talk about these antihistamines. First antihistamine we are going to talk about are the first generation H1 receptor antagonists. So this is the older generation of histamine antagonists. Your example medication is diphenhydramine. You guys probably know diphenhydramine is Benadryl. This drug is going to, like in the picture on the last slide, block that histamine receptor so that it is unable to stop the allergic reaction, the cascade that happens from that histamine. So it's going to stop that blood vessel constriction. It's going to stop the respiratory constriction, stop that capillary permeability. It can actually decrease salivation and tear formation. So it's basically going to dry you up. So like we said, these first generation antihistamines like diphenhydramine, it's going to block the histamine receptor so that that histamine cascade doesn't start. We can use it to treat allergic reactions. It can also help with motion sickness. And interestingly, we can use it to treat insomnia. A lot of people that take like Tylenol PM, if you look at the ingredients in it, it's going to have some Tylenol and then it's going to have diphenhydramine, because the bad thing about these first generation antagonists are they are going to make you so tired, but they work really good. And then another kind of interesting thing about these is if you give diphenhydramine to a child, they may have a paradoxical effect. What's a paradoxical effect? Paradoxical is the opposite effect. So if you give it to an adult, we're going to be very tired. If you give it to a child, it can get crazy hyper. So be careful when you're using this with children. As far as our adverse effects, that's CNS depression, right? Super drowsy or sedation, as well as the anticholinergic effects like dry mouth. You might see some urinary retention or constipation. Because of those anticholinergic effects, you want to avoid giving these medications to people that have glaucoma or BPH because we can make it a little bit worse. As a nurse, when I'm giving these first generation H1 receptor antagonists, if I'm giving it to older adults, I want to be careful because we can actually make them a little bit more confused. They can get dizzy, they might fall, so it's a little bit dangerous for elderly people. This drug is also going to thicken secretion, so it may make it harder for people to cough or blow that drainage out. So they are going to get really stuffy because it's not going to be kind of liquidy. As far as our patient education, you want to teach your patient to take this medication before exposure to that allergen. So if you know that you're going to be going outside into a field of ragweed, take this medication before you go out. That way all of those histamine receptors are capped off and that allergy reaction isn't going to help. According to the book, you may develop some tolerance to that drowsiness in a few days. I don't think that's true. I've been taking Benadryl to sleep when I work night shift for years and it still worked. But according to the book, you may build up a little bit tolerance to that drowsiness caused by this medication. Because the drowsiness is so bad, you don't want to take it with alcohol because it can be really dangerous, and be careful to avoid accidental overdose. Again, there are a lot of combination drugs that have diphenhydramine in there. So if you took, Benadryl and then you took a Tylenol PM, you're getting 2 doses of that. So be careful with that accidental overdose. So the good news is they have come out with some second generation antihistamines or second generation H1 receptor antagonists. Our example second generation antihistamines include fexofenadine, loratadine, and sertrazine. So that's your Allegra, your Claritin, your Zyrtec. Those are the good ones that help your allergies but don't make you fall asleep. So these ones don't affect the central nervous system so much. They bind a little bit more with the peripheral nervous system. They don't cross that blood-brain barrier, so they don't make you as drowsy. Because they don't make you as drowsy, they are kind of replacing the first generation antihistamines. You may also see these used in people that have chronic asthma, because as we're going to learn in the next lecture, chronic asthma comes from a lot of mucus release from chronic irritation. So this kind of helps slow down some of that mucus and makes asthma a little bit better. So you may see this used in asthma patients as well as for allergic reactions. Luckily for you guys, the action is the same, so it makes it really easy to memorize these drugs. Our second generation antihistamines, just like the first, are going to fill that receptor site and prevent the action of the histamine. We're going to use these to treat seasonal allergies, minor allergic reactions like itching, and like we said, with some chronic asthma patients. As a nurse, if we are giving these second generation antihistamines, couple things we want to think about. The second generation antihistamines are going to be much safer in older adults because they're not messing with the central nervous system. They're not, making them so drowsy and dizzy that they can just fall over. We do want to be careful, though, in patients that have renal failure because the excretion might be a little bit slower, so you can build up to a toxic level if you give it to renal failure patients. So be careful there. As far as patient education, very similar. Make sure that you're taking this medication before your exposure to the allergen. Make sure that if it is a nasal spray, you teach them the proper use of the nasal spray. This is a great chance for you guys. If you don't know the proper use of a nasal spray, flip back through your book and find the proper use of nasal spray. You want to continue to avoid taking this with alcohol and be careful again of that accidental overdose. All right, question number 4. This is a wordy one. Listen up. When explaining the options for antihistamines to a patient, the nurse explains that a second generation H1 antagonist differs from a first generation H1 antagonist by A, cause greater CNS sedation, B, are available by prescription only, C, are more cost effective, or D, do not cross the blood-brain barrier. Our correct answer is D, do not cross the blood-brain barrier. So remember, those second generation antihistamines like fexofenadate, those are our newer guys. So these newer guys don't cross that blood-brain barrier, so they have less CNS effects, less sedation, much better medication. All right, here we are on chapter 33, drug therapy for asthma and bronchoconstriction. So this last chapter is a little bit heavier on medications than the previous 2 chapters have been. We are going to do a little bit of review about asthma and bronchoconstriction, some of those conditions that we're going to treat with our medications, and then we're going to go into the medications. I would recommend you guys taking a little bit of time to make sure that when you're looking at these drugs, you know if it is a bronchodilator or if it is a steroid. Make sure you know the proper way to give an inhaler, because most of these medications are going to be inhaled. But we'll talk about those as we go. Let's get started on chapter 33. So chapter 31, we talked about upper respiratory. Then we talked about allergies. Now we're going to talk about our lower respiratory tract. So remember, our lower respiratory tract includes your trachea, your bronchi, and your lungs. So some common symptoms that we're going to see that are affecting that lower respiratory tract are going to be airway hyperresponsiveness, bronchoconstriction, inflammation and swelling in the mucosa, and excessive mucus production, right? These symptoms are usually going to be caused by asthma, bronchitis, or emphysema. We're going to talk about all of those conditions in a little bit. I kind of like this picture, though. You can see how this airway hyperresponsiveness, the inflammation, the excessive mucus, how they are really going to make that airway tight. So there's hardly any room for air to move in and out because there's so much mucus, there's so much inflammation in there, really clamping down on things. So let's talk a little bit about asthma before we talk about our medications. So asthma is going to be caused by an IgE hypersensitivity. That IgE hypersensitivity is going to be a type 1 hypersensitivity or an immediate hypersensitivity. And it can start happening at any age. Asthma is more common in African Americans and Hispanics. Asthma is a little bit different than an allergic reaction because it can be stimulated instead of by things like food and inhaled allergens. It can be stimulated by a lot of different things: viral infections, environmental irritants like cleaning chemicals, stress, high emotions, strenuous activities, even the weather. So really cold, dry air can sometimes cause asthma flares, temperature changes, even some kind of medications can lead to some asthma flares. So those stimulants are going to cause muscle constriction. That's going to lead to that airway narrowing. And that's the start of the inflammatory response. So we were talking about the allergic response before. Now we're talking about the inflammatory response. So that inflammatory response is going to be caused by mast cells, just like our allergic response. But this time, instead of releasing histamine, they're going to release cytokines. And those cytokines are going to lead to inflammation. Long-term outlook, if you have asthma, is not too bad if it's mild to moderate. So you kind of have it's a chronic illness, and it's going to kind of have, exacerbations or kind of flares, and then kind of go back to your stable version. And you can try to avoid the triggers and manage your flares to prevent long-term damage. If you have advanced or severe asthma, that chronic inflammation and damage is going to be less reversible. It can actually lead to long-term complications and structural changes from a lot of scar tissue building up in those lungs. And again, I have a quick video for you here about asthma. I think this one's about 7 minutes. So like I was saying with asthma, that stimulus, whatever it is, stress, cold weather, viral infection, that stimulus is going to cause a hypersensitivity reaction. And then it's going to start that inflammatory cascade. So our signs and symptoms of an asthma attack or an asthma exacerbation or acute flare, all of those mean the same thing: asthma attack, acute flare, exacerbation. All of those are going to have signs and symptoms that include dyspnea, so shortness of breath, wheezing, because those airways are so tight. You can kind of hear the musical sound of the air trying to get in and out as it's, stressing through that really tight airway. You'll see a chronic cough, a decrease in peak expiratory flow rate. So peak expiratory flow rate, or PERF, that's how hard when you blow out, how much air you're getting out. So because the airways are so inflamed, it's hard to blow out really hard. So you'll see a decrease in that expiration. You're going to have varying symptoms from mild to severe. Again, the acute flare or exacerbation can last minutes to hours. The worst type of acute attack is called status asthmaticus. So in status that's a mouthful. Status asthmaticus, the usual treatments aren't working. It's the most severe type of asthma attack. Your patient's going to be in severe respiratory distress, and it's life-threatening. So we need to get on these patients and get some medication for them. Two other conditions that are very similar to asthma caused by bronchoconstriction are chronic bronchitis and emphysema. So to be diagnosed with chronic bronchitis, you need to have a frequent productive cough for more than 3 months out of the year for 2 consecutive years. So say January, February, and March of this year, January, February, March of next year, then you can be diagnosed as chronic bronchitis. In chronic bronchitis, the increased mucus leads to airway narrowing and leads to some chronic changes. And then in emphysema, we've got enlargement and destruction of the alveoli from long-term damage. Usually we see emphysema with smokers. So this destruction of our alveoli leads to enlargement and decreased surface area available for the exchange of oxygen and carbon dioxide. So because these alveoli aren't elastic any longer, that carbon dioxide is getting trapped inside your lungs. Again, difficult for exhalation in this case. So I generally teach emphysema is the pink puffer and chronic bronchitis is the blue bloater. I don't know if you guys have seen this yet, but here it is. You'll probably see it again next semester in adults when we're talking about bronchitis and emphysema a little bit more. So pink puffer, they're pink because they've got that CO2 retention. You're usually going to see pursed-lipped, prolonged expiration. So remember, it's difficult to breathe out. So they kind of purse their lips together and a long breath out. You're going to see a large barrel chest because they have to work so hard to exhale that those muscles get really big. And then in the chronic bronchitis, we've got the blue bloater. So he's cyanotic. He's got a productive cough from all of that mucus blocking his airways. And again, you're commonly going to see the blue bloater, the chronic bronchitis, and chronic emphysema when we are talking about chronic smokers. So the next thing we're going to talk about happens from chronic changes from having chronic bronchitis and emphysema. So chronic bronchitis and emphysema together are known as chronic obstructive pulmonary disease, or COPD. So COPD is usually from long-term inhaled irritants, again, like cigarette smoke. That leads to chronic bronchitis and emphysema, and then as the person ages, continues to smoke, it is converted over into COPD. So it's a chronic condition, chronic bronchitis and emphysema. Usually, again, with the long-term exposure to cigarette smoke, your symptoms are going to be more chronic. So instead of just having it for like a couple months, this is going to be a constant situation. They're less reversible at this point, so it's a more severe form. You're generally going to see a lot of shortness of breath, some activity intolerance. They're so short of breath they can't really do very much. And you see air trapping, again, where they have a hard time exhaling. So they get that big barrel chest and they do that pursed lip breathing to try to squeeze out some squeeze out some oxygen. I put a nice picture over here for you to kind of get familiar with COPD. Again, all these conditions are very similar, so our medications are going to be very similar. All right, we finished the first chunk of the lecture. We're on to question number 1. Is the following statement true or false? There are no long-term side effects from asthma. Hey, look at this. We are already on to question number 1. Is the following statement true or false? There are no long-term side effects from asthma. Brr, that one's false. Remember, chronic asthma can lead to structural changes, scar tissue, airway remodeling, so it can be pretty dangerous. Same thing as chronic bronchitis and chronic emphysema. They're going to lead to those chronic changes and scar tissue, leading to COPD. All right, question number 2. Patients with bronchoconstrictive disorders will report difficulty with which of the following? A, inhaling, B, swallowing, C, coughing, or D, exhaling. All right, correct answer is D, exhaling. So bronchoconstrictive disorders, we've got asthma, we have got COPD, chronic emphysema, chronic bronchitis. So those bronchoconstrictive disorders are known to make exhalation difficult because excess mucus and airway narrowing from that inflammation make it difficult for the air to exit, and this is called air trapping. So the air gets trapped in those alveoli. It's difficult to exhale. I like this picture over here. I mean, let's be real, I love all the pictures, but I like this picture. You can see in inspiration that air is able to slide through, because when you're inhaling, it opens up the airways a little bit. When you're exhaling, it causes those bronchial walls to kind of close in a little bit, and then that mucus really traps the airway. So that air kind of just circulates through there, and it's not able to get the fresh air in with the exhalations. So when we're talking about these bronchoconstrictive disorders, we've got a couple goals in drug therapy. So because that airway inflammation is one of the big offenders, we want to prevent that airway inflammation. That's going to cause the, difficulty with the exhalation and kind of the root cause of the problem. So we want to prevent and minimize that airway inflammation. We also want to minimize the use of rescue drugs. So we talk about 2 different types of drug therapy when we talk about these chronic disorders. We talk about maintenance drugs. That's something you take every single day to prevent that airway inflammation. And then we talk about a rescue drug, which is if you're starting to get kind of a flare-up, then you need to take something to kind of rescue you from that situation. That's something that you use on an as-needed or PRN basis. But because we want those drugs to still work really well, we want to use them as little as possible. So we want to kind of maintain you on a daily basis with your maintenance drugs, and then just save those rescue drugs for emergencies. Our main treatments are going to make a lot of sense, right? If you understand that the inflammation is the big bad guy with these bronchoconstrictive disorders. So our main treatments are going to be bronchodilators. Bronchodilators are going to open up those bronchi. That way you can breathe in and breathe out. And then we're going to use some anti-inflammatories. Remember, one of the causes of that bronchoconstriction is inflammation. So if I can give you an anti-inflammatory, it's going to turn down that big inflammatory response that's causing that swelling of the airways, causing that bronchodilation. Because we are talking about just this being a lung problem right now, if we're giving bronchodilators as an inhaler, it's going to be the most effective treatment and the first choice to relieve asthma. So doing a inhalation is going to be better than taking an oral medication, right? So like I said, we have two main treatment plans, right? The rescue inhalers and the maintenance inhalers. Maintenance ones are going to be the ones we take every single day to help keep the inflammation under control. Our rescue ones are the ones that we're going to need when we are in a tight situation. We need a rescue, basically, right? So this is going to be true with our first drug group that we're going to talk about, our beta-2 adrenergic agonists. So these medications come as a rescue inhaler. This is going to be quick relief. It's a short-acting drug. Again, it's going to be used in an acute flare or an exacerbation. And then we have that maintenance inhalation. These are long-term drugs used to control our condition, achieve and maintain control of our condition. So our beta-2 agonists are examples. We have two drugs. One's going to be a rescue, so the short-acting. One's going to be a maintenance, so it's a longer-acting drug. Our short-acting is albuterol, so that's going to be your rescue, your short-acting. It's going to work in the time of emergency. It works quickly, and you only want to use it as needed. Our long-acting beta-2 is going to be salmeterol. That one's going to be more of a maintenance. You're going to take that one every single day to keep the symptoms at bay. So our drugs in this class are going to stimulate beta-2 receptors in the smooth muscles of the bronchi and the bronchioles. So it's going to help relax those muscles. The cyclic AMP, you don't really have to worry about that. It's going to help to further cause bronchodilation. So, the take-home point is these beta-2s, albuterol and salmeterol, they're going to stimulate those beta-2s, and that's going to cause bronchodilation. So it's going to open up those bronchi. All right, so our beta-2 agonists, these drugs are going to be used to treat or prevent bronchoconstriction. They can be used in children and older adults. We're safe there. Sometimes you'll see very large doses given in critical care units and short-term use. These drugs are available as a nebulizer. So that's where it's like aerosolized. An MDI is a metered dose inhaler, like a little puffer, a handheld inhaler. It's also available as an oral medication. But remember, we want the inhalation first because it's going to go directly to the lungs. Oral would kind of be the second choice for us. As far as adverse effects, the big one we want to look out for is cardiac stimulation. These can cause tachycardia. You might also see some CNS stimulation, so anxiety, problems sleeping. They get you so ramped up that you might start having a little bit of a muscle tremor. Because of that cardiac stimulation, you do not want to give these medications, so they're contraindicated in anybody that has heart dysrhythmias. If they have coronary artery disease, if they have hypertension, we want to avoid giving those medications. So be aware of your patient's cardiac status. All right, so as a nurse, what are we thinking about when we are giving these beta-2 adrenergic agonists? So this one's really exciting, right? First thing right off the bat, if we're giving beta blockers, remember those are our cardiac drugs, our LOLs, we're going to block the effect of this medication. So the beta blocker is going to block our beta-2 agonist as well. So it may cause bronchospasm because we're blocking the effect of this medication. We also want to be careful with medications like thyroid hormones, theophylline, cold medications, caffeine. All of those things can be made even stronger by the CNS stimulation that happens with these beta-2 agonists. Patient teaching, most important one on this list, make sure we're using the bronchodilator inhaler first. So the whole idea is if I do the bronchodilator inhaler, it's going to open up my airways. I'm going to give it 5 minutes to work. And then if I have another inhaler, which is usually a steroid inhaler, I'm going to use that one second because then my airways are open really nice and big and that medication is going to get way deep down into my lungs. So use that bronchodilator first. You want to wait 5 minutes in between inhalers. So you can do your puffs of your bronchodilator, wait 5 minutes, do your puffs of your steroid inhaler. You want to make sure to teach your patient, if you're using your rescue inhaler, that short-term rescue beta would be albuterol, right? So don't overuse your albuterol rescue inhaler or it won't work as well. If we're talking about the maintenance inhaler, the salmeterol in this case, don't skip or overuse your maintenance inhaler. So don't skip a dose or don't take 2 doses because you're not happy with your symptom control. Call your doc. Also, last part, make sure your patient knows how to use their metered dose inhaler or their MDI. I know that you'll never see this in practice, but the proper way to use an inhaler is to put the inhaler 2 finger widths from an open mouth, press the inhaler, take a slow, deep breath in, and then wait 3 to 5 minutes, and then take the second puff of that inhaler. Again, slow, deep breath in. You don't want to do a quick because that's going to suck it right into your mouth. You want it to get down into the lungs. So you're going to take a nice, slow, deep breath in. That way it gets down there into those lungs. I didn't put it on here, but an important thing to teach your patient is if they are not getting relief from their rescue inhaler, that they need to call 911 or teach the family if the patient's in severe respiratory distress, having an acute attack, you need to call 911. Our second drug class that is going to work to prevent bronchoconstriction are anticholinergics. So our example drug is going to be ipratropium. Ipratropium works to block the action of acetylcholine in the smooth muscle. Again, what's important is it's going to slow that bronchoconstriction and slow the mucus secretion. Ipratropium, an anticholinergic, is going to be a maintenance therapy drug for bronchoconstriction. It is not going to treat an acute attack. It is maintenance medication. It is available in a nebulizer, aerosolized, or in an MDI, so a little puffer inhaler. Generally, you're going to see ipratropium used in a combination with another bronchodilator. So again, our anticholinergics like ipratropium are going to be used for maintenance to prevent bronchoconstriction. They are not going to be effective for an acute attack. It's more of a maintenance. So again, don't skip this dose. Take this dose daily. It's a maintenance medication. Some people have asked me why they would give an anticholinergic for a maintenance drug rather than the beta-2s. The anticholinergics do not have the cardiac stimulation. So if you have cardiac issues, an anticholinergic is going to be a better drug choice for you. The only adverse effects that we have with these anticholinergics are going to be our anticholinergic effects. So dry mouth, some GI upset, a cough, not too bad, right? These drugs are going to be contraindicated with narrow angle glaucoma and BPH, again, because those anticholinergics dry things up, so you'd make those conditions worse. Our next class, we have the xanthines. Our example drug is theophylline. So theophylline is another bronchodilator. It's going to work by relaxing the smooth muscles. Usually, theophylline is saved for pretty severe cases of bronchoconstriction. It can be pretty toxic, and it's got some pretty severe adverse effects. So we save this for the most severe cases of bronchoconstriction. As far as adverse effects from our xanthines, like theophylline, big one we have to worry about is toxicity. So signs and symptoms of toxicity include anorexia, nausea, vomiting, agitation, tachycardia, even seizures. So because of those pretty severe adverse effects, like I said, this isn't a med we give commonly. We save it for really severe cases. Theophylline is going to be contraindicated in patients that have gastritis, peptic ulcer disease, or seizure disorders, because those can be made worse by those adverse effects. As far as a nurse, when we're giving this drug, again, it's an older drug. It's saved for really severe cases. Along with toxicity, there's a lot of drug-to-drug interactions, so we have to be careful when we're giving this medication because of a lot of drug-to-drug interactions. And a really interesting thing that would really set this apart and make it a really good test question, xanthines like theophylline, cigarette smoking can increase the metabolism of the drug. So let's think about this. If we're smoking cigs, it's going to metabolize this drug a little bit faster. So if I would stop smoking my cigs, then my drug's not going to be metabolized as fast. And then what can happen? Yes, toxicity. And that's our big concern with this medication. So interesting, really important patient teaching is the patient needs to tell the doc if they're going to stop smoking, because they have a really high risk of becoming toxic with this medication. You also want to teach them not to take excess medication, because it's going to give us that high risk of toxicity again. All right, so we made it through the bronchodilators. We're moving on to question number 3. A woman begins using an albuterol inhaler and a steroid inhaler for her asthma. The patient asks if it matters which inhaler she should use first. A, you should use the albuterol inhaler first, followed in 5 to 10 minutes by your steroid inhaler. B, you should use the steroid inhaler first, followed in 5 to 10 minutes by the albuterol inhaler. C, the order you use the inhalers doesn't matter. Or D, you should not use the inhalers one right after the other. And our correct answer is A. You should use the albuterol inhaler first, followed in 5 to 10 minutes by the steroid inhaler. So remember, we want to use that bronchodilator first. One of our bronchodilator inhalers was the albuterol. So take the bronchodilator first. Remember, give it 5 minutes. That's going to open up the airways. And then when they take the steroid inhaler, that steroid is going to get deep down into those lungs. And speaking of steroids, look at this. What a segue into slides, right? It's like I've done this before. Our next medication class are going to be our corticosteroid inhalations. Our example is going to be beclomethasone. Beclomethasone is going to help decrease airway inflammation, and it is going to help decrease that inflammation by blocking the cytokines. Remember way back in the beginning when we talked about how asthma attack happens. So remember, asthma attack happens when something stimulates our mast cells, and instead of releasing histamine like an allergy, they're going to release cytokines, which is the inflammation. So this is going to block that cytokine, and it's going to stop the inflammatory cascade. So we're going to block it and that's going to block mucus secretion. It's going to block edema. It's going to help to prevent and repair epithelial damage, so damage to the tissues in that airway, and it's going to reduce airway reactivity. All right, so our corticosteroid inhalers like beclomethasone. So my big study tip for this, throughout pharm, this is probably one of the only drugs that this is legit true. Steroids are going to end with ONE. So if you see a medication that ends with an ONE, know it's a steroid. So in this case, that beclomethasone, ONE, think steroid. So anyway, steroids like beclomethasone, we're going to be using those as a prevention and treatment of asthma and COPD. Kind of depends on the dose. Higher dose is going to be used in treatment, lower dose is going to be used in prevention. Over the long term, you can use this in combination with the bronchodilators to try to prevent flares. Again, we want to try to use the inhaled medication that's only going to affect our lungs, because we're talking about lung conditions here. So that inhalation is going to be the best to only have an effect on our lungs. As far as adverse effect with our corticosteroid inhalations, headache, you might have some dry mouth and cough. Big one you want to think about is fungal infection. So I put this gross little tongue on there. This is somebody that has a fungal infection, candidiasis or thrush. High risk for that when you're taking these steroid inhalers. This medication is going to be contraindicated if you've had recent nasal or oral surgery, because one of the side effects of steroids is it's going to slow down the healing process. So we won't want to do that after having recent surgery. So as a nurse, when we are giving corticosteroid inhalations like beclomethasone, the big thing with the steroid inhalers is we want to make sure that we are rinsing the mouth and spitting it out. And we want to do that because it helps to prevent that fungal infection, that thrush that we talked about on the last slide. So we can also, like I said, use different routes. So maybe in the hospital, you'll see somebody get IV corticosteroids. We want to wean those off slowly so your body kind of adjusts to it. So we want to use the lowest dose necessary to control our symptoms. So when you're having an acute flare, you might have to have a higher dose. But when we're talking about maintenance, you want to use the lowest dose possible so that we still have some room to grow if you start to have an acute crisis. So lowest dose necessary to control those symptoms. As far as patient teaching, corticosteroids you want to take on a regular schedule. This is not a rescue inhaler. This is a maintenance inhaler. So take it every single day. Even if you're feeling groovy, you still want to take this steroid inhalation. Again, use your bronchodilator first. Wait 5 minutes. Then use this corticosteroid inhaler. And then what's the big thing? Everybody shout it out. Rinse. Oh, I said mouse. Rinse your mouth after use. Rinse your mouth after use. Sorry about that typo. So our next couple of drugs are just going to be some kind of random, less commonly used medications. First one we're going to talk about is a leukotriene modifier. Our example drug is going to be montelukast. So this one's actually an oral tablet. So this montelukast prevents the leukotrienes from binding to the receptors, and that is going to lead to reducing bronchoconstriction and inflammation. This drug is going to be a good use for long-term treatment of asthma. Again, reducing inflammation, reducing bronchoconstriction is the main thing we want to do to kind of maintain people with asthma or COPD. It's not going to be effective in relieving an acute attack. Again, this is going to be a maintenance medication. And the kind of interesting thing about it is it's going to be an oral medication, not an inhalation. So like we said, the leukotriene modifier, like montelukast, is going to prevent acute asthma attacks that are caused by allergens, exercise, cold air, hyperventilation, irritants. It helps to block those leukotrienes that are released by all of those things. It can be used in combination with bronchodilators and with corticosteroids. So you're generally going to see it used in combination because this medication only works in kind of preventing that inflammatory cascade. As far as adverse effects, we've got headache, nausea, vomiting, diarrhea, the usual stuff right there. But then we have this black box warning for neuropsychotic events. So neuropsychotic events are things like vivid dreams, agitation, hallucinations. So pretty serious black box warning with this drug, right? All right, so next drug is going to be a mast cell stabilizer. Our example is going to be cromolyn. So these mast cell stabilizers prevent the release of the inflammatory chemicals by the mast cells. They're usually the second line treatment. They are used as a maintenance medication for mild asthma. Cromolyn, again, is going to be for a maintenance medication, not effective in acute problem. And our last medication is a monoclonal antibody. So monoclonal antibodies, these are going to be these drugs that end with MAB. We're going to talk about these throughout pharmacology. They are like the newest, hottest thing, scientifically created in a lab to do all this really cool stuff. So with this medication, our monoclonal antibody, our med is omalizumab. It is going to bind with IgE and block the receptors so that there's less IgE available. Remember, IgE is one of those antibodies that starts the allergic reaction. So if there's not a lot of them available, it's harder to start that allergic reaction. So we can use this as adjunct therapy for severe allergic asthma that's not well controlled. So we know a lot of people that have, for example, peanut allergies. If they get exposed to peanuts, their airway starts closing off. They get, a lot of wheezing, a lot of inflammation, hard time breathing. We can give this medication as well as something for that allergic reaction to help block that allergic reaction. There is a pretty serious black box warning for this medication because there's a risk of life-threatening anaphylaxis, which is kind of funny, right? When this medication is supposed to block allergic reactions, but it has a black box warning of causing a life-threatening allergic reaction. But it's out there and can be used in certain cases. That's your monoclonal antibody. All right, so I just want to take a second and talk about combination medications. I talked a couple times about the bronchodilators and the inhaled steroids. So here's a couple examples. You'll see these really commonly in the hospital or even out, in people's homes using these combination medications. So you'll see, 3 meds in one for your Trelegy. You'll see 2 meds in one with this other medication. It just kind of depends on what your patient situation is. They make these combination inhalations because the MDIs are so expensive that a lot of patients are non-compliant with them, or they'll take one and not the other. Like the steroid doesn't really help them, they think. So they'll only take their bronchodilator. So they make these combination ones so that you can get, 2 or 3 drugs in one inhalation. Makes it more cost effective, makes it better for patient compliance. So don't feel like you have to know these drug combinations by any stretch, but I just kind of wanted to explain those. You'll also see Duoneb. We see this a lot in the hospital. This is a combination of ipratropium and albuterol. So with these, you get a fast acting and a longer acting. So you get a little bit of immediate relief and then a little bit of maintenance relief. So these are really nice in the hospital for someone having an acute problem, so that you get, that immediate relief, but then you also get some continued long-term relief from that combination drug. All right, and then last time that I'm rambling on, I think. So organizing your medications when you're studying, you need to make sure you know what medication is going to be a reliever. So what's going to treat an acute problem. The only medication that we talked about that is going to be a reliever or a rescue inhaler is going to be albuterol. Then we talked about our maintenance medications or our controller. So our maintenance medications, we talked about salmeterol and we talked about ipratropium. Then we've got preventers. So these medications work to prevent the issues that cause the flares. So they prevent the problem. So we talked about theophylline, we talked about beclomethasone, we talked about montelukast, we talked about cromolyn, and we talked about omalizumab. So when you're thinking about your meds, think about, is this med a reliever? Is this med a controller? Or is this medication a preventer? And this will help you kind of keep them straight in your mind. All right, question number 4, guys. Is the following statement true or false? In acute severe asthma, a topical corticosteroid is indicated for a patient whose respiratory distress is not relieved by an inhaled beta-2 agonist. All right, the correct answer was false. That's garbage. So what are you thinking about when you're thinking about this question? So in acute severe asthma, we're going to need to use a systemic steroid. So something like an IV steroid. We're going to need a high dose in an acute severe asthma attack. So if your patient's respiratory distress wasn't relieved by an inhaled beta-2 agonist, you're going to need a systemic steroid. A topical cream, so that's like a lotion. That's not doing jack for you. Topical corticosteroid isn't going to help at all. An inhaled corticosteroid may help a little bit, but we may have to kick it up a notch and get that systemic corticosteroid. So topical, make sure that you picked up on topical in that question. Topical means I'm going to rub it on my skin. So that's not doing jack for a severe asthma attack.